Thank you, Amay, and the organizers. So my topic is neuroendocrine neoplasms, the present and the future. So to begin, what are neuroendocrine neoplasms? These are a heterogeneous group of neoplastic epithelial proliferation, and they range from well-differentiated tumors to very aggressive polydifferentiated carcinomas, be it a small cell or a large cell neuroendocrine carcinoma. For establishing a diagnosis is by symptomatology, biomarkers, imaging, and finally by histopathology. So till today we are doing. However, sometimes the diagnosis can become difficult as symptomatology is subroutine and it's non-specific, while imaging requires sophisticated technology and is expensive and not always widely available. So what does clinician want from pathologists while dealing with neuroendocrine neoplasms? They want us to be more precise and have an unbiased diagnosis. The various parameters used in the classification, like mitotic count, the MIB or the Ki67, and necrosis to be stated clearly. And as we know that neuroendocrine have a site-specific nomenclature as per the WHO. So depending upon the site, there is varied nomenclature for neuroendocrine neoplasms. There has been an attempt to make it a uniform nomenclature across the organ systems so that the clinicians accept it widely. However, and because of the varied nomenclature, there is a confusion among the pathologists as well as the clinicians, whether it's a neuroendocrine tumor grade 3 or neuroendocrine carcinomas. However, as we can see here, that in lung we still follow the carcinoid, atypical carcinoid criteria. In pancreas we have a well differentiated neuroendocrine tumor grade 3, a neuroendocrine carcinoma, whereas in other places we follow a grade 3 as a carcinoma. There had been an attempt to classify them, like we can see in this we have a 2015 classification which was on the basis of small cell, large cell carcinoid, but in the upcoming 2021 classification there has been an attempt to make it uniform as per the other organ systems. But still, till date, we are still following the carcinoid and the atypical carcinoid. Why is this in lung? Because majority of the lung neuroendocrines are polydifferentiated, being it a small cell or a large cell, and very small proportions are true carcinoids or atypical carcinoids. So this is how a pathologist uses the diagnostic criteria for diagnosing a typical and atypical carcinoid. So usually less than 2 mitosis per 2 millimeter square, there is absence of necrosis, and a size more than 5. In atypical, everything can be same. The mitosis increases, it has to be between 2 to 10, and or necrosis is present. This is a histomorphology pictures which show an organoid pattern. There are it can show glandular, but those are pseudoglandular and nests of tumor cells. Neuroendocrine tumors have a varied pattern. There can be rosette, there can be spindle cell, oncocytic, papillary. This may lead to a diagnostic dilemma. In large cell, it looks like any other epithelial carcinomas, but the mitotic index is high, like more than 10. Then maybe there is necrosis, sometimes large cells, and in comparison to small cell where there is scanty cytoplasm, crushed nuclear morphology, hypochromatic cell, these cells usually have a low N/C ratio. They look like any other carcinomas. They have nucleoli. They may have fine or post chromatin, but on immunohistochemistry they show positivity for neuroendocrine markers, which may be one or more. Typically we use synaptophysin, chromogranin, INSM1, and CD56. Similarly, when we come to gastropancreatic, again the classification is based on the basis of morphology, the mitotic count, and the Ki67. So as we see, grade 1 less than 2 mitos, MIB1 labeling index, and so on. And the carcinomas now are classified those which have more than 20 mitosis, more than 20 MIB, and a polydifferentiated morphology, be it a large cell or a small cell carcinoma. Thus it involves integration of both the morphology as well as the proliferative index for classification. So these were the changes in the current WHO, that there were some changes in the cutoff. Initially for grade 2 it was less than 2, now it has made less than 3 for MIB1. There has been removal of grade 3 neuroendocrine carcinoma which was used in the past. Now there is a neuroendocrine carcinoma as a separate entity, and we have a neuroendocrine tumor which can be a grade 3. Again, this is how morphology can be solid, cystic, and the patterns as we described can be variable. So like we have nest, glands, a sheeted pattern. We have to carefully look for mitosis because it drives the classification as per the number of mitosis per 2 millimeter square. And these are the new immunohistochemical markers like chromogranin, synaptophysin. So as the tumor becomes poorly differentiated or undifferentiated, we can make out that there is decrease in the expression of the neuroendocrine markers. So many times you may not, ideally they say for diagnosis you should have at least 2 neuroendocrine markers positive, but sometimes you may not get that as there is loss of expression when the tumor becomes poorly or undifferentiated. So there is a need of new markers or a big battery of immunohistochemical stains to diagnose a poorly differentiated neuroendocrine tumors. Many times we receive biopsies which are very crushed and very small, and morphology may not be distinct. In such cases, MIB1 can be helpful to diagnose, to grade the tumor. Like you can see, there is hardly any MIB1 here, and this tumor has full of staining for MIB1. So more than say 90% here, with a crushed morphology becomes a small cell carcinoma. So there are some issues of Ki67, especially because of tissue fixation, the storage time, like if there's a big time gap between the specimen resected and sending to the pathology lab, there is drastic decrease in the MIB1. For all these reasons, MIB is still not used as an indicator in lung, because it is not a better predictor than mitosis, and there is no specific threshold for typical and an atypical carcinoid. So in lung, whether it has a role in tumor grading, it has any predictive role? No. There may be a prognostic role probably if the tumor has a high MIB, you may say that it may not behave properly. So now this was all about how we practice now as per the neuroendocrine tumors, using the immunohistology, the immunohistochemical markers, giving importance to your mitosis, MIB. Now in the last decade there has been a lot of discoveries as per the molecular signatures. So I'll divide it into lung and gastropancreatic because they share a difference in the molecular signals. So when we see neuroendocrine tumors of the lung, like carcinoids, they usually have a low mutation rate, and they have been divided into 3 molecular subgroups. One is the cluster A, which is the true carcinoid, which usually shows overexpression of ACL1, DLL3. Then there is a cluster 2, which has another set of mutations, a ROBO1, SLIT1, as well as HNF1 and FOXA3. This was A1, A2, and there is a cluster B, which has some overlapping with the gastropancreatic neuroendocrine tumors, which they show somatic mutations in MEN1 and FOXA3. So this is how the clusters are divided. So these are the 3 clusters, and as we see that they have a difference in as per their molecular signatures, they have difference in their survival. The cluster 1 has a survival of 80, overall 10-year survival of 88%, cluster 2 has 83, and the cluster 3, which has MEN1 or HNF or FOXA3, has a survival of 60%. So similarly, the large cell neuroendocrines are also divided into in 2 groups. The carcinomas typically harbor a TP53 or a retinoblastoma 1. There is a high frequency of this and loss of RB1 identified. Across the neuroendocrine tumors, neuroendocrine carcinomas, be it at different sites, this P53, that is tumor suppressor gene 53, and RB1 inactivation is uniformly found. In addition, they are divided into 2 groups. One is like a small cell lung carcinoma like genomic profile. So morphology, it may look like a large cell carcinoma, but its genomic profile are like a small cell. Another is same, it has some overlapping with mutations seen in adenocarcinomas, be it P10, KRAS. So these 2 subsets are there for large cell neuroendocrine. So they have been divided into 2 groups. One is P53 is seen in both. In addition, this group will have ACL1, DL3 or notch low, and the other group will have the reverse of this. They may have a neuroendocrine profile which is similar to small cell, and they can be treated or targeted as per their mutations. So this is the reason why it is necessary to subtype all the neuroendocrine tumors as per their molecular, because we may have targeted therapies in future. So coming to small cell again, as I said, that all carcinomas have inactivation of RB1, or there is a biallelic inactivation of PP53. This is uniform across the board. Small cell additionally has Notch family genes abnormality in at least 25%. Those which may have overlapping with adenocarcinoma like morphology, or may harbor say KRAS or any kinase gene mutations are also reported, but this is a very small proportion. More than 70% will have classify small cells in the last decade. So there are various authors which have been divided into initially divided into two groups, like the ASCL1, group 1, Neuro D1 is other group, and those which were negative were quoted as group 3. So last decade has been seen a lot of changes in this. There has been subclassification. So group which was double negative was found out to be harboring two other mutations like the YAP12 253. So although this is recent paper which proposed a nomenclature that the small cell lung carcinomas can be molecularly divided into 4 groups. One is the small cell lung carcinoma A, which is the ACL1 high group. The second group can be the Neuro D1 high. The third group, which stands Y, is the YAP10, and the fourth group is the PU2F3. So this is how the current nomenclature has been proposed. This is not accepted or divided, but this is what Rudin et al. Had proposed. Why he did this? Because when we compare this to histology, the group 1 and the group 2 has a pure histology. They demonstrate the neuroendocrine markers, which is like synaptophysin, chromogranin, INSM1, CD56. Whereas the other two groups, they have low expression, they may not have a uniform expression of immunomarkers of neuroendocrine. They have low expression of ASL1, Neuro D1, and they have increased expression of YAP or PU253. So this was they quoted, that when we classify them as per this neuroendocrine groups as per their molecular signatures, we can have a targeted therapy along with directed against them. So it is necessary, rather than treating them as one basket, they quoted that this has the mutations associated with ASCL1. So these are the potential targets available for them. So this is how they propose to treat and classify. This tells us the need that why we should molecularly classify the neuroendocrine tumors. So as I said, like this is a neuroendocrine carcinomas, maybe small cell, large cell. These were the 4 groups which we just described. And the large cell, we had 2 groups, 1 and 2, and a small cell like large cell neuroendocrine carcinoma. Across the groups, the mitosis is high as per the histology. The MIB1 is high. The key genomic mutations are the P53 and the RB1, and the survival is less. So this is what we see at histology, but molecular level, they are totally different from each other. So this is where we have to target the patients to have a better treatment of the patients. Coming to gastropancreatic, again pancreatic nomenclature keeps on changing again and again. So this was the nomenclature which we have, which has a grade 3 neuroendocrine tumor and a neuroendocrine carcinoma. This created a lot of confusion. Now the WHO says that tumors which have a small cell or a large cell morphology should be classified as neuroendocrine carcinoma, and there should not be any grade attached to it. So they become a neuroendocrine carcinomas, whereas grade 3 neuroendocrine tumors are those which are reminiscent of neuroendocrine tumors but have a mitosis of more than 20 or a MIB of more than 20. Most of them have a mitotic MIB1 less than 40%, whereas tumors which have a MIB1 of more than 55% go into neuroendocrine carcinomas. So the gastropancreatic neuroendocrine tumors, most of them harbor these mutations, be it MEN1, commonly seen in familial cases, the DAX, ATRX, the P10 or the tuberous sclerosis protein. So the familial ones, majority will show MEN1 in addition to VHL, NF gene or tuberous sclerosis. When we come to sporadic types, the DAX, ATRX is which are mutually exclusive, is the most common mutation seen. Second is MEN1. So again, in GI or gastropancreatic, it is important to identify because they have prognostic significance. So mutually exclusive somatic inactivating mutations in either DAX or ATRX is reported in almost 40% of the cases. So what happens? So what they do, they result in telomere dysfunction. So telomere is basically how the cell life is calculated. So this results in the non-homogeneous homologous end joining, which results in alteration in telomere length and causing genomic instability. So the cell which are supposed to die or has to undergo apoptosis undergoes some genomic instability and undergoes proliferation. So as I said, like the morphology can be anything, but the molecular signature can be different. So this is ATRX which is retained but the DAX is lost. This is another case which shows ATRX loss and DAX is retained. So these are mutually exclusive in most of the cases. Still we can have some cases with the molecular signatures. There are IHCs which are available, so it can be done at a faster rate. Instead of going for a long time consuming molecular, this can be done as per your routine testing. So when we see ATRX and DAX, ATRX is the one which has more significance in comparison to DAX for survival, because patients with a loss of ATRX have a 10-year survival of 54 and 0, 5 and 10 year survival of 54 and 0 is as compared to those which have retained ATRX. Additionally, multivariate analysis showed that the risk of LVI, perineural invasion, is more in ATRX loss, and the overall survival is poorer with ATRX as compared to DAX. So as I said, we can do this in your routine lab while doing your HNE. Look at the morphology. If there is a high grade morphology with a high mitotic and a high MEB, you can do your testing for ATRX and DAX. If there is loss, it becomes a neuroendocrine tumor grade 3. Or if it shows loss of P53 or the RB1, because RB1 also can be tested by IHC, it becomes a neuroendocrine tumor. So till this level you can do in your using your immunohistochemistry. So this was a paper in 2018 which showed that loss of ATRX has a markedly decreased overall survival compared to those patients with retained ATRX. However, when DAX was negative, there was not much of difference in the overall survival. When we come to metastatic pancreatic neuroendocrine or gastropancreatic neuroendocrine, they in addition to DAX, ATRX, they may show ARID1, CDKN2A mutations. So patients which do not harbor these mutations have a better survival, whereas if harboring these mutations, either of these markedly decreases the survival to around 40%. So as we discussed, neuroendocrine carcinomas have this loss of retinoblastoma 1 gene or TP53 mutations. It's seen almost in 50 to 70% of the patients. And last two slides about the recent NET test. So NET test is basically like your using your liquid biology, liquid biopsy. So this is more useful in identifying patients who are asymptomatic or who do not have any specific symptoms but are at a risk, and you want to screen them, or whether you want to check the response to treatment or the progression of the disease. You can do a NET test, which is basically identifying the mRNAs, and using mathematical algorithms you derive a score which will give you where the patient stands in this. So basically it's a transcriptomic signature for neuroendocrine tumors and has a good accuracy. So it will capture what is the tumor biology, what mutations it has, and the disease activity as per his genomic content. So less than 20 indicate there is no disease, whereas 21 to 40 in a patient who has a disease will indicate there is a stable disease. With increase in score, it indicates that there is a progressive disease. So this is how this has been used in Western population. It's not done here, but this is how they can stage or this is how they can stratify or triage their patient that who is progressing, instead of going for tissue biopsies, which gives you your findings of that moment. Comparison in compared to that, liquid biopsy will give you a real-time overview of what is the genomic activity of the tumor, what mutations it carries, how much is the tumor burden right now, and how it has evolved over the time. So with multiple tests, it will tell you whether the patient is progressing, it's stable, or is responding, and it becomes a real-time information at a very faster rate. So this is about NET test. So this is my final slide for how to conclude. That the molecular signatures in neuroendocrine neoplasms is ever evolving. It gives an idea how the tumor going to behave, and also to categorize the tumor in different groups for better targeted therapy as well as for the patient care, and in future to identify more genomic signatures to classify and treat them as a separate patient rather than a one basket of patients. For pathologists, if you don't suspect a neuroendocrine tumor, you cannot detect it, because morphology is very much similar in cases of especially large cell neuroendocrine. It may look like any other carcinoma. So you should have a strong suspicion to identify a neuroendocrine tumor. Thank you.
Thank you, Dr. Subhash. A couple of questions from my side. Especially in case of pancreatic neuroendocrine tumors in grade 2, which is the preferred molecular marker in a resource constrained setting like ours, if we have to prognosticate a patient? ATRX should be the one single marker we should use.
Ideally, all neuroendocrine tumors will have ATRX or DAX, which is the most common. What we can do at our level is ATRX, because it is easily available. First of all, because if you say resource constraint, and it's a nuclear marker, so its reporting is also better. You can report it better. It is not non-specific staining is less in those, and it has a good correlation with the overall survival also.
And in case of non-pancreatic JEPNETs, is there any role for molecular markers, especially the rectal NETs, where the outcome is already poor?
So non-pancreatic, ideally the mutations are more or less similar, but right now there is no role for it. So we have to go for pancreatic. Yes, we have to classify. Most of the GI or gastropancreatic will show MEN1 mutations, but right now we don't target them that way.
Thank you very much. I don't think we have any further questions. Thank you, Dr. Subhash.
Listen, multiple perspective. So if we do set ATRX, if positive, you showed the outcome is good, mutations is there, and if not, outcome is really poor. And it's 20 versus 69, and looks like what you're saying is true for any neuroendocrine tumor, yes, any part of the body.
That was tumor, not for carcinoma.
Not for tumor, correct. But what it means that if it is negative, looks like they're behaving like carcinoma. Am I right?
If it's negative, yes, they are behaving like carcinoma.
Okay.
There may be some other mutation which we have not tested, or it's not in the discovered now, which is driving the disease and behaving aggressively.
But it's a good predictor. Yeah. So, so has there been any movement in trying to intensify treatment for these patients? That because 0% it looks like we are talking about a neuroendocrine tumor. If we tell our patients, we have a feeling we are talking about some slow growing. Here it looks like there is a type of it which is really not slow growing. No, it is not, because but I agree we should have been answering that question, but I thought you have.
In our practice also we don't do also ATRX.
We don't do
in our routine practice.
Okay.
We should be like off late we have started doing on pancreatic, but because this data is also all very recent, last 2 or 3 years, but as a protocol, we should be doing in all neuroendocrine. We have ATRX IHA in our lab. We should
Oh.
be doing in that.
Please.
We should do that.
This will be very valuable information.
No, me and Amay, like we have discussed also. Like we do it in pancreatic, but we should be doing in all neuroendocrine.
Okay. So very nice presentation. Thank you.